Hey guys, this Camtasia is going to be about HIV and some other immunodeficiencies that I'm going to add in there. So one of the first things you need to realize is that HIV is the most common secondary immune deficiency disease in the world. So essentially, HIV stands for Human Immune Deficiency Virus. So what it is, it's a virus that's looking for a way into a cell. Once it gets in that cell, it takes over the cell and it replicates more of the virus that then enter the bloodstream. So HIV's favorite cell to hijack is a CD4 cell. Remember, we learned about CD4 cells when we talked about in module C, and then also when we talked about this immune system in general. So remember, your CD4 cells they play a major function in your immune system as far as recognizing self versus non-self cells. So your book goes into a lot of detail, but essentially what's happening here, the T cell is no longer an immune helper cell, but it instead becomes an HIV factory, and it's making up to 10 billion HIV cells a day. Well, in the beginning, remember, your body can keep pace with that. However, over time, just the sheer number of HIV cells overwhelms the immune system. So when that occurs, you have a decrease in your CD4 T cells, and you have an increase in your viral load. And that's when your patient starts showing signs and symptoms of HIV. So now that you know what the definition is of HIV, I always like to present some of the history of HIV. Realize that HIV has actually been around for a very long time. The first case was diagnosed in 1959. A man in the Belgian Congo died from an HIV infection. So the current theory is that HIV originated in Africa. It started out as an SIV, which SIV is a simian immunodeficiency virus. So simian meaning primates. So what happened was it jumped from primates to humans, and then once humans were infected with this virus, it became HIV. Now, in the United States, the first cases were diagnosed in 1981, and these cases occurred among gay individuals, specifically gay men. And so the general population at the time just thought that this was only a quote unquote gay disease. Now, please realize the mindset of the people during that time, and also realize that we really had never been introduced to this virus before. It was new, and we knew that it just occurred among gay men. So that's kind of the background for it. So as I said previously, this disease occurred among gay individuals, and so that's why it was often referred to as a gay disease. This individual right here, probably a lot of y'all don't know him, but his name is Ryan White. He received HIV from a blood transfusion that occurred in the 1980s. So what Ryan White did for us is he brought awareness to the fact that HIV was not just a gay disease, that anybody could get HIV. And so what you have to realize is for healthcare, this led to a lot of fundamental changes. There was a lot of research being done after he contracted this, as far as how can we treat this? Is there a cure for it? Because he got it through a blood transfusion, this is one of the reasons we started screening blood in the 1990s. And so the thing that was sad about the Ryan White case is his family went to the school board and told the school board that their son had HIV. Because of that, the school board expelled him from middle school because he was HIV positive. So again, guys, you think, oh, that's horrible. And it is, but you just have to realize the times we suddenly have this new disease, and we thought it only occurred in one population, and now it's occurring in different populations, and we have no way of treating it. And so what that led to, it led to the enactment of an act, and it's called the Ryan White Act. And what this act says is that students and or People that are employed by schools do not have to disclose their HIV status. And so that's one thing that came about of Ryan White's family coming forth. So the sad thing is, remember, at this time, he contracted it in middle school. We had no treatment for it. And that's what you have to realize. So he died at the age of 19. So I love to give you FY information and give you facts and figures to kind of emphasize how many people are affected by HIV. But currently, we have 37 million people living with HIV worldwide. Now, realize that's just an estimate. There are certain areas of the world that don't report HIV status. There's several reasons for that. One is they don't have access to testing facilities or testing supplies, and two, they're in very rural, isolated areas that are hard for healthcare workers to get to. So there is a lot of people that are impacted by HIV. Another thing you have to realize is HIV is still continuing to occur. Again, just look at the figures I gave you for Americans in general. We still have 50,000 people in the United States that become infected each year with HIV. There's estimated to be over 1.1 million people in the United States that have HIV. And the scary thing about this, guys, is only 1 out of every 7 people are aware of their HIV status. So people could be infecting other people not knowing that they actually have HIV. So realize in healthcare, you are going to interact with people that have HIV, just based on these sheer numbers. I talked to y'all a little bit about the global impact. Now let's look at the United States. Demographically, HIV. So realize that this is just based on the latest demographics, but you see that your African American population, they are hit hardest by HIV, followed very closely by your Hispanic Latino population. And so what that tells us is that we have got to improve in our education. In the United States, only 34 states require mandatory HIV education. Half of all the new diagnoses were made in California, Florida, Texas, New York, and Georgia. So if you look by region, the South is where most of your newest diagnoses are being made. And I know it's not surprising to you, but in the state of Alabama, we are one of the states that do not require any kind of education on HIV. So this is something that, for those interested in public health, it's a huge deficit that we definitely need to look at, and we really need to educate on HIV, because we know that HIV is a very preventable virus. It's very fragile. It doesn't live long outside the body. So we just need to educate people about ways to prevent the transmission of HIV. So I know I gave you some demographics on HIV in the United States. I also like to talk about some of the populations that are at risk. Demographically, when we look at it, women are one of the fastest growing groups that are diagnosed with HIV worldwide. So that's one thing that we have to realize. So what I always like to talk about is when a woman comes into a clinic for pelvic inflammatory disease, STDs, cervical dysplasia, or if the female has a persistent or recurrent yeast infection, those are all things that kind of point us in the way of maybe we need to test this individual for HIV. And the reason that is because if someone has STDs, then we know they are exposing themselves to HIV because they're not having protected sex. If someone comes in with recurrent yeast infections that we've treated and the patient has been educated on proper hygiene, but yet they still have these infections, then remember yeast is an opportunistic infection. And so we need to maybe dig a little deeper, ask some more questions. The other thing I like to talk about is I know I told you that African Americans and our Hispanic Latinos are make up the majority of our new HIV diagnosis, but I like to kind of throw some numbers out there to you because I can tell you that, but it doesn't really hit home till I tell you 1 in 16 black men will be diagnosed with HIV, and then 1 in 32 black women will be diagnosed. Again, when you look at black women, their rate of infection is 16 times higher than a Caucasian woman. It is the 6th leading cause of death for African American men between the ages of 35 and 45, and it's the 4th leading cause of African American women. So we have got to look at these populations and see how can we as healthcare providers intercede in stopping this epidemic and in educating these populations. A key point you have to remember about HIV is has different stages of it. Realize that HIV starts out as just HIV and it progresses to AIDS. So AIDS is end stage HIV. The distinction of where we put somebody at in the different stages is primarily based on the number of CD4 cells a person has, and if they have developed any type of opportunistic infections. So when I talk about opportunistic infections, and I have a slide in here that I'll go over some of them, but those are infections that a person with a normal, healthy immune system should not get. They are not considered contagious. So remember when you're looking at your CD4 cell count, a normal range is 800 to 1,000 cells for a cubic millimeter of blood. So that is your normal. So when you start going below that, that's when you start having signs and symptoms. But one thing you need to remember is a person with HIV, they can transmit the virus to any other person at all stages. But they are considered especially infectious right after being infected, just because at that point in time they have a very high viral load. The other thing you need to realize is that once a AIDS diagnosis has been given to that patient, then that stays. They can't go from a diagnosis of AIDS just back to HIV stage 1 or stage 2. Once the person has been labeled AIDS, that kind of sticks with them throughout the rest of their healthcare journey. So the progression from HIV to AIDS depends on several things. It can take months to years for it to progress from HIV to AIDS. So I like to talk about some of the things that play a factor in the progression. One thing is HIV, it depends on how it was acquired. If it was acquired through contaminated blood, it's going to convert more quickly to AIDS versus from one sexual encounter. And so that's what I want you to realize there. Some other personal factors that play a role in how fast the progression is. One is nutritional status, stress, poverty, because remember with poverty, those individuals have limited access to medications, either one, because they can't get to the clinics to get the medication, or two, simply the cost of the medications. So all of those things contribute to how fast HIV progresses to AIDS. I always like to put this slide up here because this is a famous athlete that most of us know that has HIV. He is what we term a non-progressor. Now realize only about 1% of people with HIV can be termed non-progressors, but what happens with these individuals, it has been discovered they have genetic abnormality with their CD4 cells. And so what happens is the HIV has a really hard time binding with certain receptor types. So if the HIV can't bind with the CD4 cells, then what happens is they're not producing the number of or I should say, the number of HIV cells that a person with a normal CD4 cell is producing. So to be termed a non-progressor, realize it is a person who has been infected with HIV for at least 10 years and they've remained asymptomatic and their CD4 cells are within a normal range. If a person meets that criteria, then they're what we are termed a non-progressor. So yes, I know this athlete right here is famous and he has money and he can probably afford the latest and greatest. I know that, but he is a non-progressor. And so he is one person we look for, or people like this 1% are people that we look for when we are trying to develop a cure or a vaccine to prevent HIV. So we're not there yet, no matter what you've heard. There is currently not a cure for HIV. Once you have it, you will always have it. But we're looking at doing research with these non-progressors and looking at their DNA and their genetic abnormalities to try and develop some type of solution for the HIV epidemic that is currently taking place worldwide. So I've talked to you about some of the populations that HIV is growing in the fastest, the populations we really need to gear our education to. So some take-home points. One is there is no cure for HIV. It does not matter what is posted on social media. It does not matter that somebody's brother, sister, cousin has informed you that they had HIV and they no longer have it. Please don't believe that. There is no cure. What we have done is we have developed, and I say me, I mean healthcare workers in general or scientists have developed drugs that are so effective in slowing the disease process that they can actually get a person's viral load, meaning how much HIV they have in their body, down to 0. And that's absolutely wonderful, guys. But to be effective, those drugs have to be taken at the same time all the time for the duration of that patient's life. And the other thing you have to realize, as soon as they stop taking that medication, that viral load is going to increase. So that's one thing I really need you to realize. So there is a very high mortality rate with HIV. So what we focus on, one, for our people that have HIV, is drug compliance. That's a major focus. But for our people that don't have HIV, what we need to focus on is preventing it. As I've told you before, HIV is very fragile. It doesn't last very long outside the body. We have determined the modes of transmission, and so education is our best hope. So we need to be educating these individuals about HIV and how to prevent HIV. So that being said, HIV is found in almost all body fluids. I've listed here all the body fluids that HIV is found in. However, realize the highest concentrations of HIV are found in the semen and in vaginal secretions, breast milk, and blood. So when we do our education, those are kind of things we focus on the most. The three most common ways to acquire HIV is sexual, parental injections, or perinatal. So remember with perinatal, that's the transmission across the placenta during pregnancy, and also with the vaginal birth, the infant is exposed to blood and secretions during birth. So we used to automatically, if we had a mother that was HIV positive, we would do a C-section. However, evidence-based practice has found that it's actually better to do a vaginal delivery on a woman who is HIV positive to deliver the baby vaginally than it is for a C-section. Now, we still do not want the mother to breastfeed, and the reason that is because, remember, there's higher concentrations of HIV in breast milk. So while now currently we promote vaginal deliveries among HIV positive women, we do not promote breastfeeding among HIV positive women at this time. When you think about sexual transmission, remember we have oral, genital, and anal. So the reason we worry about genital sex is because there are a lot of mucosa membranes in the vagina. And remember, anytime you have mucosa membranes, there is the potential for tearing. And so, because of that, HIV is more easily transmitted from an infected male to an uninfected female than vice versa. While, yes, it could occur the other way, it is most easily transmitted from an infected male to an uninfected female because a female has they have more mucosa membranes, they have a greater potential for tearing. So when we think about anal sex, realize when I talk about anal sex, it doesn't matter if it's male to male or male to female. With anal sex, you have a vast number of mucosa membranes all throughout. And so the problem with that is the more mucosa membranes are, you have an increased risk for tearing. So remember, any of those tears, that's an entry point for HIV. So you have a greater likelihood of contracting HIV through this method because of all the mucosa membranes. So when we talk about sex, we just need to talk about safe sex. So when we talk about safe sex with our populations, we need to talk about the safest method is abstinence. But if that's not a possibility or we know that's not going to occur, then we need to talk about other things. So I just always think about, remember your ABCs: abstinence, be faithful, and wear condoms. So realize that with condoms, they're still not 100% effective, they're just safer. Also with condom use, remember it needs to be used consistently and correctly, and that it should actually occur, that condoms should be put on before the sexual act begins. Also, a condom, or safe sex I should say, is the responsibility of both partners. So these are things when you're educating that you need to talk to people about. The number one way that healthcare workers transmit HIV is through needle sticks. So because of that, we need to really stress that our healthcare workers, you need to wear gloves, you need to follow safe practice as far as sharps about not recapping dirty needles, and to be careful and make sure and engage your safeties through this. Besides just needle sticks, healthcare workers can also become infected through exposure of non-intact skin. And so that is why we stress standard precautions. To try and prevent their transmission, we need our people to use standard precautions, because this right here is what is recommended by the CDC. However, what you have to realize is if a healthcare provider has been exposed to HIV, let's say they stuck themselves or they came in contact with non-intact skin of an individual that they know has HIV, what they have to follow their policy and procedures is about when do they report. But the biggest thing is they have to report right away. They don't wait to the end of the shift. They don't wait until they're caught up with their charting. If you have a needle sharp injury, you follow your chain of command. You go to your charge nurse. You let your charge nurse know, because there's a protocol in place at every hospital on how to treat this. Because realize now what we do is we test you, we test the patients. Best outcomes for needle stick injuries is if we start prophylactic medication within 2 hours of exposure. That's the best outcomes. And so that's why that timeline, it really has to be followed. And as soon as it occurs, you go to your charge nurse and follow your policy. What we can do for someone who has been exposed to a potential, or I should say, we call it post-exposure. But we do something called CART therapy. So CART therapy is essentially just combination antiretroviral therapies. What we can do, we like to start it while it is most effective within the 2 hours from exposure. We need to start it within 24 to 36 hours, and that individual, that healthcare worker, will continue it for 28 days. So Again, the biggest thing we can stress here is just using best practice and use standard precautions in all your patients, because you can't look at a patient and tell that they have HIV. Things I want you to remember about testing. Remember, there's no such thing as an anonymous test when you're talking about HIV, and the reason that is because everything is tracked. It is tracked statewide. It is tracked nationally, and so when someone has a positive HIV test, then it has to be reported to the health department. However, realize that you have to follow your hospital's policy on reporting. Primarily, it is the physician that is responsible for reporting it, but just realize that the law requires those to be reported because they need to be tracked, and we need to see what kind of trends we're doing statewide and also nationally and globally with HIV. So while there's no such thing as anonymous testing, it is confidential. Okay, so it's a need to know type of thing. Other instances, remember that in most cases of an HIV test, it does require informed consent. So if a physician writes an order, or he puts a order in the electronic entry area for an HIV testing, that's not something the lab is just going to come up and automatically do. The patient needs to sign a consent. They have to give permission for an HIV test to occur. Now, the cases where that's not accurate is, remember, prison inmates, they don't have to give consent. They are automatically tested when they enter the prison system. The other thing is, we can get a court order of testing for defendants charged with a sexual offense. And the reason that is because they took away someone else's rights or someone else's ability to say yes to a sexual act. And so because of that, the court takes away that individual's right to refuse an HIV testing. So those are primarily your two cases where you don't have to get informed consent. All others, they do require informed consent. We also do prenatal testing. And the reason we do prenatal testing is because HIV at that point, it wouldn't just affect the mother, it would also affect the fetus and how we provided care. Because remember, if we find out that someone has HIV and they're pregnant, they still need to be on some type of CART therapy, but they need to be on CART therapy that is safe for the actual fetus. And so a lot of times we might have to change up some of their medications. So that's one thing you need to remember about prenatal testing. So remember that 1 in 7 individuals do not know their HIV status. So one of the main things we need to educate individuals about is that all sexually active people, they need to know their HIV status. They need to be testing. The reason we stress early testing and diagnosis, because testing actually plays a role in prevention, because testing is a way of diagnosing HIV before any immune changes can occur. So it allows us to educate on risk reduction and or to eliminate high risk behavior that puts other people at exposure for contracting HIV. So the thing I like to talk about with HIV is there is this thing that we have called a window period. So this window period is a period of time where after the person becomes infected with HIV, if they were to do an HIV test, the results would be negative. And guys, the reason for this is, remember, it takes 14 to 21 days for your body to start producing antibodies before they start producing specific HIV antibodies. And so let's say a person was to have unprotected sex with an HIV positive partner one night, and they come in for testing just a week later, the ELISA test, it will be negative. even though that patient may have active HIV. So testing during this window period, it doesn't provide useful information. So that's one thing you need to realize, and that is why we always promote for people that have been recently exposed to retest at least 6 months after their last exposure to make sure that they have been accurately diagnosed with HIV. When we diagnose someone with HIV, or I should say when we suspect that someone has HIV, we will do an ELISA test. Or we can even do, we have fourth generation HIV assays, and they detect very specific IgM or IgG antibodies. Um, and so those are things that we look for first. If that comes back positive, then what we will do a Western blot to confirm that. We never just tell someone they're HIV positive based off one test result. We always want to verify and follow it up with that very specific Western blot. Some other labs that we're going to be looking at, one is their P24 antigen that is very specific for HIV. So that's another way that we can determine if someone has HIV. So we'll also look at things like a viral load. So when I talk about a viral load, that essentially measures how much HIV is in that person's body. So the higher the viral load, remember, the greater the risk of transmission. And so these are all tests that you will see when we suspect someone has HIV. Or we can run these tests like that P24 or even the viral load. We can run those throughout their treatment to see how effective their treatment is. So other things that you will notice, typically your patients will have a lower than normal CD4 cell count, and they will have a lower lymphocyte count. Please make sure you read the laboratory assessment section in the corresponding chapter. It provides you some really good information about the latest that we are doing in HIV testing. So make sure you read on that. So a key point I need you to remember is HIV. When someone has HIV, they don't look sick. You can't, they have active lifestyles. They look like there is nothing wrong with them. However, as it progresses, as that CD4 cell starts dropping, your patient will start moving through the stages and eventually progress to AIDS. And remember, AIDS is when you have a CD cell count lower than 200 and or you have developed opportunistic infections that a normal individual with a healthy immune system would not develop. So at this point right here, going forward, I am talking about the end of HIV, or I'm talking about AIDS, because there are key features that a patient has when they have AIDS. It's presented in your book. It is on page 346. You have a great little chart. It's chart 19-3. So make sure you are familiar for those, because these are the things when the patient comes in, you will start noticing with them. Also realize when you look at their history or when you talk to them about their history, things you want to ask: one, what's their age? What's their occupation? Where do they live at? Have they have a history of a blood transfusion before 1985? What are their sexual practices? Meaning, do they have protected sex? Do they have a history of STDs? Because all of these things could put them at a greater risk for developing, or I should say, the progression from HIV to AIDS. So make sure you ask those questions. You want to make sure and do a focus assessment that is presented to you on page 356. It is chart 19-7. Also, when these people come in, you want to be on the lookout for any type of opportunistic infections, any type of malignancies that are specific for AIDS. Also, they're going to have endocrine complications. They're going to have some skin and kidney changes, and we'll talk about this a little bit more in some of the slides that are following. but there's specific things you want to be on the lookout for, and chart 19-3 presents those. These are the things that are most commonly associated with AIDS. So realize in a patient that has AIDS, a priority nursing action is that you are continually assessing and documenting the presence of any type of opportunistic infection. And guys, what you need to remember about those opportunistic infections is they don't pose a threat to a person that has a healthy immune system. So some of those opportunistic infections that your patient can develop are presented here in this table I have, but they're also presented in your book. They start on page 346 under opportunistic infections, and there's also a chart. It's chart 19-1 that talks about opportunistic infections. Now, the politically correct term for it now, instead of opportunistic infection, it is AIDS-defining condition. So please don't let the terminology confuse you. They are one and the same. So some of the infections that you're going to see, one is toxoplasmosis. So realize you get toxoplasmosis. You can acquire it through contact with contaminated cat feces or by ingesting infected undercooked meat. So in toxoplasmosis, remember, you want to look for those subtle changes in the mental status and neurological defects. They're going to start complaining about a really bad headache, and they're going to start running a fever. If it progresses, what you'll notice is they can even have difficulty in their speech. They can be kind of staggering, have difficulty walking. They also can develop confusion and or seizures. So you want to make sure you do a very comprehensive mental health exam to looking for those specific mental changes. So another type of infection that this population has a lot of is when you look under fungal. I told you yeast infection is a big one. They are very prone to developing yeast, thrush in their mouth. It can go down into their throat. Remember, I told you about women. They can have yeast infections that just don't clear up. Histoplasmosis is another one that is very common in this population, and so be on the lookout for that. And then when you look at another fungal infection that's very common is PCP. So PCP, remember, stands for pneumocystic pneumonia. That is what PCP stands for. It is one of the most common AIDS-defining illnesses in this population. So what happens here is it affects the lungs, and so you need to be assessing for any type of weight loss, fever, crackles, dyspnea. They're going to have drop in their O2 sat. They're going to have very rapid breathing, and they're going to have a very persistent dry cough. They're going to complain about not being able to catch their breath. So remember, when PCP, one of our drugs of treatment, and we're going to talk about that in a little bit, but is Bactrim. So one of the problems with Bactrim is there's ingredients that actually can crystallize in the kidneys, and so that's one reason when you do education on somebody that's getting Bactrim, you want to make sure that they drink at least 3 to 4 liters of fluid daily just to prevent that crystallizing that's occurring in the kidneys. So other things that you will see, viral, you want to think CMV, that stands for cytomegalovirus virus. So remember, that can attack the eyes, and so they need frequent eye exams for that. Herpes is another one that's very common in this population. So they typically will have herpes outbreaks, or they will develop shingles because, remember, they have an impaired immune system. Bacterial infections they're prone to develop. One is MAC. MAC stands for Macrobacterium avium complex. It's the most common form of a bacterial infection that's associated with AIDS, and it is a systemic infection. They also develop TB. So remember, if you have a patient on TB, then they are on droplet precautions. So airborne precautions is what you need to worry about there. So all of these are presented to you in chapter 19. So make sure you read over them and how to care for them, because this is what you'll be dealing with once the patient has reached the AIDS status. So when we talk about some of the endocrine complications, things that can arise, remember your men are going to have a decrease in their testosterone levels. You're going to have some body shape changes. Typically what it is you have a decrease in your muscle mass. You can develop adrenal insufficiency. They often develop diabetes. They have elevated triglycerides and cholesterol. The women typically have irregular menstrual cycles. So all of these are endocrine complications that are associated with AIDS. Remember, because this population has an impaired immune system, they are more prone to develop cancers. Some of the most common cancers you're going to see in this population is Kaposi sarcoma. That is actually a skin lesion, and I have a picture for you in a little bit. I'll show you about Kaposi sarcoma, but they're also more prone to develop Hodgkin's lymphoma, non-Hodgkin's lymphoma. In your women, they are more likely to develop invasive cervical cancer, and again, remember, it's because they have a weakened immune response. That's what increases their cancer risk development. This is an example of a Kaposi sarcoma. This is the most common skin lesion associated with AIDS. These little Kaposi sarcoma, they're purplish brown and they are often raised. So the lesions can be very localized or very widespread. The thing you need to worry about with these lesions is they can be very painful. They can actually impede movement and they can restrict circulation. So realize if someone has a Kaposi sarcoma and it's open or weeping, you want to make sure and keep it clean and keep it covered, because you do not want that individual to develop a secondary infection because of the Kaposi sarcoma that is open. Because remember, again, this population has impaired immune systems. So this is a great example of a very small Kaposi sarcoma. So with this one right here, you could probably treat with this with just some local radiation and or cryotherapy. Okay, and again, it's not to cure them. It's more for comfort measures and to improve their quality of life. This is another example of a Kaposi sarcoma, but remember in the previous slide I showed you a very small Kaposi sarcoma that we could treat with just cryotherapy. This one right here, it's very widespread. So the way we would treat this is we would do chemo. And again, it's just to improve their quality of life. These skin lesions typically are very painful. And so we want to make this individual's quality of life the best we can, and so that's why we're treating it. So in a patient that has AIDS, a lot of these AIDS-defining illnesses are going to impair their respiratory system. And so you need to make sure that you maintain that respiratory function and you avoid any type of complications. So you're going to make sure that you assess their respiratory rate, their rhythm, their depth, what's their breath sounds, what are their vital signs, what are their O2 sat. You want to make sure and provide O2 as needed to keep their O2 sat within a defined range. You might even need to humidify the O2. We want to make sure that we elevate the head of bed to facilitate breathing. Also realize that this population gets very tired, and so we need to provide rest for them, and we got to make sure and pace our activities. They might actually need to have mechanical ventilation, or we might even have to do some suction. And also keep an eye on those ABGs, because that kind of tells you the overall picture of a patient's respiratory status. So these are things you want to monitor, because you know that person has an increased risk for inadequate gas exchange. So among this population of individuals, oftentimes pain is a major issue for them. Typically, what causes the pain is they have enlarged organs or they have tumor development and/or invasion. They also can develop peripheral neuropathy. It's either from the disease process itself, or it could be from some of the drug therapies that we implement into their treatment plan. So all of that can cause pain. So things you want to look at is you want to be able to provide comfort measures. So I gave you some examples. These individuals typically, when they become end stage, they become very thin. They start wasting away. So they're more prone for skin breakdown. So they want to make sure and change the positions very frequently. Also, you want to use lift sheets because it is painful for these individuals to move. We also will try and medicate with some drug therapy, and I gave you some examples of that. And then another thing we often can try is something called guided imagery. So that might work. Also, a lot of this population will like to use acupuncture. They can use pain relieving mattresses. We can do warm baths or some other form of hydrotherapy. Um, they can also use massage or even hot and cold to the painful areas. So these are all things that we'll try and do to alleviate that person's pain and improve their quality of life. So in your AIDS patient, they are at an increased risk for imbalanced nutrition. And so you, as a healthcare provider, you're going to have to come up with some interventions to combat this. So I provided some examples. One, what are their food preferences? You want to make sure and monitor those daily weights. In this population, they do better with 6 small, high calorie, high protein meals a day. And so that's kind of what you need to shoot for. We can supplement them with vitamins, things like Ensure. If that doesn't work, we can do some PPN or we can even do some TPN. Our main goal here is to build them back up because we need them to have the protein needed to combat all the infections that they have going on. Other things you want to make sure and do, imbalanced nutrition, it could be because they have developed thrush or yeast or nausea, vomiting. So if someone has thrush, then we would anticipate getting an order for diflucan. If nausea and vomiting is an issue, then let's go ahead and put some medications on board to help prevent that nausea and vomiting, because we do need them to eat the meal and then actually be able to keep the meal down so they can absorb those nutrients. Diarrhea is another thing that is very common in this population. So the reason they develop diarrhea is because they have either developed a fat intolerance, and so for that population we want to avoid dietary fat, or they become lactose intolerant, and this can either be a result of HIV or just a side effect of some of the antiretroviral medications that they're having to take to deal with their HIV status. And so things you want to realize is dietary changes is one of the biggest things you educate them on. If they're lactose intolerant, then let's avoid that. We also want them to eat less spicy, less sweet foods, not as fatty. We want them to not drink alcohol, not drink caffeine. We also want them to eat less roughage. So these are all things that we can do to try and help combat that. So one of our main goals as healthcare providers is to monitor the HIV progression and the immune function. The other thing we want to do is we want to slow the conversion from HIV to AIDS as much as possible. We do that with drugs, with medications. Our main goals in drug therapy is one, we want to decrease the viral load, but at the same time, we either want to maintain or increase a person's CD4 counts. We also, again, like I say, we want to delay the development of any type of AIDS-defining illnesses. When we started out with HIV, what we found out is we started with something we called monotherapy, meaning just one medication is what we gave. But what research showed us was treatment with just one um, medication, it actually promoted drug resistance, and it didn't improve the patient's quality of life or even their duration. And so what we use now is we use a cocktail. We refer to this cocktail as CART. So CART stands for a combination of antiretroviral therapies to treat HIV, because we realized we needed more than one drug to treat HIV. So an important issue with CART is compliance with the medication regimen. And the reason that is because, guys, HIV is so smart. And with any of your smart viruses, it can mutate. We don't want HIV to mutate anymore because then we will have to deal with different strains of it. So it is very critical that the patient realizes these drugs cannot be missed, they can't be delayed or administered in lower than prescribed dosages. Because if they do, then two things. One, it's not going to be effective for the individual. And then the other thing is it's actually going to contribute to development of medication resistant HIV or mutations in HIV. And we don't want any of that. So as I've stressed before, CART therapy is what we use for patients that have HIV. Again, you need to make sure that the patient is aware of the importance of taking these medications exactly as prescribed so that they stay effective. There's lots of different drugs we can use, and everybody will not use exactly the same because we have all these different types. These are presented in your book. There's a chart, it's 19-6, it's common examples of drug therapy. You also have a drug list that talks about it presents the medications you need to know for this module. But when you're talking about HIV drugs, some of the more common ones, you have the nucleoside reverse transcriptase inhibitors. What these do, they actually fool HIV into thinking that they are a CD4 cell. And so what happens is the HIV binds with this instead of the real CD4 cell. So it tricks them. And so that way the DNA synthesis and replication are actually suppressed. But when you think about your NRTs, or what we usually refer to these about, remember that typically they have some really bad side effects, and they're presented to you on page 351 in the chart 19-6, so be aware of these. Now, your non-nucleoside analog reverse transcriptase inhibitors, again, these actually bind directly to the HIV enzyme that's needed for viral cell replication. So this is, again, another option for people. We have the protease inhibitors. The protease inhibitors, it actually blocks the HIV protease enzyme that's needed. One of the latest and greatest are these fusion inhibitors. Actually, what fusion inhibitors do, they block the fusion of HIV with a host cell. So they block the fusion between HIV and your CD4 counts. So while these drugs, they don't cure HIV, what they're mainly focusing on is decreasing the viral load and either maintaining or increasing the CD4 count, because if we can do that, then we can delay the progression from HIV to AIDS, or we can delay the patient with HIV developing an AIDS-defining illness. So these are our goals with this. We also now have a medication. Truvada you've probably heard about or seen some of the commercials. That's one of our pre-exposure prophylaxis. It's a pill that the individual will take once a day, and if they take it as directed, then it will reduce the rate of transmission by 90%. So we typically will recommend this for someone who is in a high risk behavior. So let's say they are a prostitute, or they work in the sex industry and they have a higher than normal risk of developing HIV, or contracting it, I should say, HIV. We'll recommend this. Or if a person's in a committed relationship with someone who has HIV, we will recommend the use of Truvada, and again, we will also recommend the use of condoms. But it's pretty neat. It's talked about in your book on chapter 19. It is talked about under drug therapies. So again, be aware of that one. Also, we like to use some complementary or alternative therapies. A lot of individuals will turn to vitamins or botanical products to help them with dealing with this disease. So, you need to be aware of your drug therapies because that's going to be a big part of your care in this population.